welcome you all to this first session of our GIN 2020 conference replacement, a pit stop in the COVID-19 marathon. Today, or right now, we are starting with the first session, which will deal with quality of evidence for guidelines and recommendations. Session 2 will be taking place later today. Session 3 is tomorrow, session 4 on October 2nd, 2020. I will start with a very brief overview for those of you who are new to GIN, about GIN itself, and then say more about the webinar, and we will get started with the actual speakers in just a couple of minutes. So GIN has as a vision to produce trustworthy and accessible guidance, as a mission to lead, strengthen, and support collaboration and work with the guideline development, adaptation, and implementation community. GIN is a network of and partnership. It assists members in reducing duplication of effort and promotes the best practice through the development of opportunities for learning and building capacity. Session 1 today in this, as we said, COVID-19 pit stop in the marathon to really surpass difficult times, will focus on quality of evidence in guidelines and recommendations. And I'm really excited, together with my co-moderator, Miloslav Klugar from the Czech Republic, to start introducing our 4 guest speakers for today. The session will last for 2 hours, and presentations or interventions will be from Laine, Dr. Christine Laine, the editor-in-chief of the Annals of Internal Medicine, Dr. Stewart Spencer, the senior scientific editor at the Lancet in the UK, Dr. Karla Soares Weiser, the editor-in-chief of the Cochrane Library from the UK, and Dr. Gerd, former head of Cochrane Germany from Freiburg, Germany. And just to explain a little bit more about the objectives for today, here is a brief overview of what these objectives are. We are going to review issues about the quality of preprints, the integration and systematic reviews and guidelines and recommendations, the quality of the evidence that is presented and included in guidelines, and we will try to give it an evidence user and guideline developer perspective, and this will be in particular the role of Miloslav Klugar and myself, as well as the audience. So we really thank you for joining us today and hope that you have a very positive learning experience, and really are looking to actively encourage you to participate in today's interactive session. You can submit questions and comments that Miloslav and I will be monitoring in the chat box, and we'll be reading out loud as they come in when we get to those sessions. As we have indicated, today's session will last for approximately 2 hours. You are registered for 2.5 hours. This is simply so that the session doesn't end suddenly or abruptly when we are still talking. So 2 hours approximately, and there will be time for questions and answers after each speaker, and we will then have plenty of time for discussion at the very end of the session until the end of the session. This question has already been placed in the chat. A recording of the session will be available on the GIN website when we have completed our session. There's a good reason for addressing what we are trying to address today. There is an overwhelming amount of literature coming in particular around COVID-19. We very superficial approaches to gauging what the volume of that literature really is shows that a simple title search in PubMed indicates that we are already facing the same number of citations for COVID-19 in not even a year that is registered in PubMed since the beginning of registering scientific literature for atrial fibrillation. Same number of citations, over 40,000, about 1/5 for tuberculosis, and we are approaching influenza in terms of the number of citations that have arisen in the last year alone. So I'll start with the declarations of interest, and then I'll turn it over to Miloslav Klugar for a few words. So the declarations of interest, Christine Laine is the editor-in-chief at the Annals of Internal Medicine, a senior vice president at the American College of Physicians. She's employed by the American College of Physicians. There is no direct conflict of interest here from mentioned by the other speakers. Miloslav, over to you for a few words, and then I will introduce the first speaker.
Thank you, Holger. So good morning, everyone. I'm Miloslav Klugar, and I'm now in Brno, Czech Republic, Masaryk University. And welcome all to Gin Pit Stop in the COVID-19 marathon. And as a first, it's my pleasure to introduce Professor Christine Laine, a general internist and epidemiologist. She's editor-in-chief of Annals of Internal Medicine and senior vice president of the American College of Physicians. Her substantial experience in medical journalism and scholarly publishing is evidenced by leadership roles she has held in the International Committee of Journal Editors, the Council of Science Editors, and the World Association of Medical Editors. She is professor of medicine at the Sidney Kimmel Medical College, Thomas Jefferson University in Philadelphia, where she participates in patient care and teaching. And it was my pleasure to collaborate with Christine also while preparing the program for the Gin Pit Stop in the COVID-19 marathon. So Christine, you can upload your slides and you can start.
Miloslav, it's not letting me share my screen. Wait.
Right.
There we go. Yeah,
Right.
all good.
Okay, good morning, good evening, good afternoon. We're coming from all over the world. I'm in the same time zone as Holger, so it's about 5 a.m. in Philadelphia, but it's a pleasure to be here with all of you anyway. I'm going to give my perspective, obviously as a journal editor, because that's how we spend our time. Annals of Internal Medicine publishes many systematic reviews and meta-analyses and guidelines, and our editors have expertise in this area, and our statistical editors have methodologic expertise in this area. So we have been a place where many of the evidence reviews related to COVID-19 have come for peer review. Holger already mentioned my conflicts of interest are related to my employment for the journal and the American College of Physicians. The journal publishes some of the material that I'll be talking about, and the American College of Physicians has a clinical guidelines group. It's one of the Cochrane affiliates, and so I have special relationships with those two entities. So this is what I think guideline developers must feel like. You can change the labels on this, and you can write that the editors are in the boat and the emerging evidence and the manuscript submissions. But there really has been, as Holger mentioned, an overwhelming amount of new literature coming out in the during this pandemic. And I think that whatever your role is, whether you're a systematic reviewer, a guideline developer, a clinician, importantly, a journal editor, we are all struggling to make sense of this, really this tsunami of new evidence. While I'll be using the COVID-19 literature as the example here, I think that this experience has really emphasized and brought to attention many issues that all of us in this arena have been struggling with dealing with growing evidence, because over time, the number of journals is increasing, the number of preprint servers is increasing, the number of researchers and the output of those researchers are increasing. In order to begin to tackle some of this, living reviews and living guidelines have been a topic that has been talked about for the last several years. But I think the pressure of getting literature out quickly to help clinicians and patients during the pandemic has really pushed us at the journal and others to figure out how to really do this. So in May 2020, Annals published our first living review and associated guideline recommendations, and we outlined a plan for how to publish review updates as evidence surveillance continues. And over this period, many challenges have emerged, and I think I will be presenting more challenges than answers, but I think GIN is a really important venue for all of us to begin tackling some of these questions and developing a plan for how to handle them as we learn during this pandemic. This is basically the struggle. It's a struggle between speed and quality, and it's a delicate balance. I think that you can be fast and have high quality research done and high quality peer review, but particularly it's easy to be faster when there are only a few pieces of evidence that you're trying to quickly pull together. And Annals of Internal Medicine has a fast track review process. Typically, we would have, under 10 papers that were going through a fast track review at any given time. And during the pandemic, we pledged to expedite the review of all of the pandemic-related material. And when the volume increases, there's a struggle. Our editors are working harder and faster. Our peer reviewers are working harder and faster. And we're all trying to navigate this delicate balance between speed and quality. This has brought to light several issues. The first issue I want to talk about are preprints. Preprints have been around for a long time, but at least in the clinical literature, they've really exploded during the pandemic. The potential benefits of preprints is they avoid delays due to the peer review process. They're freely and widely available to everyone. There's no subscription wall. Others can act immediately on the findings, but there are also potential harms. And interestingly, the potential harms completely overlap with the potential benefits. So it avoids delays related to the peer review process and some of the quality checks that peer review process provides. They're freely and widely available to all, even to people in the public, in the government, who make decisions on them, but may not have the knowledge base to rate the quality and the cautions that go with that evidence, and others can act on the findings immediately. There are some more potential harms. The preprint servers do not systematically disclose potential conflicts of interest. Many of them do not have a commenting feature that's viewable by the public. The same work can appear on multiple preprint servers. There's no systematic indexing, although the National Library of Medicine in the US is working on a process. And we have seen cases where systematic reviewers have counted the same study that was posted in 2 different preprint servers as two separate pieces of evidence, but it really was the same piece of work, just posted in two places. And none of the preprint servers actually require the researchers to link to subsequent, excuse me, peer-reviewed versions of the work. So when the research does go through peer review and it often changes in that process, there's no systematic way to indicate that in the preprint servers. So preprints and guidelines, I said I was going to emphasize more questions than answers, and particularly on this issue, I'm going to pose questions. Things that have come up as we've been reviewing evidence reviews during the pandemic, many of them include preprints, and the editors, the researchers themselves, and our peer reviewers are asking, should guideline developers include evidence available only, excuse me, in preprint form? Should the preprints be rated differently than peer-reviewed publications? Are the preprints permanently archived? There's also no requirement for that. So if a guideline is based on preprint materials, is there any assurance that people will be able to go and look at that, or that primary evidence after the fact? And should recommendations that are based on preprints be rated differently? And when evidence is initially posted as a preprint and is vetted and published, should the guideline be updated to reflect that fact? And as I said, I don't have answers to these questions, but I think that this audience are the perfect people to begin to discuss how to approach some of these issues. When we're quick, we all make mistakes. And during the pandemic, there has been an increase in the number of corrections and retracted articles. And we have no systematic way, if a guideline is living, the retracted literature could be incorporated into an update. But what about guidelines that are not planned to be living documents? If there is a retraction of a piece of evidence that was important in formulating those recommendations, should we have some mechanism to update the guideline to reflect changes in that evidence? And should the other question, which existed long before the pandemic, but again has been exacerbated by during the pandemic, is should recommendations be offered when evidence is absent or weak? And on one hand, you have people who say clinicians and patients need guidance now. They can't wait for the randomized controlled trials to be complete. The guideline developers have to provide recommendations. And on the other side, people are arguing that once a recommendation is incorporated into practice, it can be really difficult to change behavior even when new evidence emerges. So I think that the clinician community is also wrestling with this. If you read a guideline that tells you you don't have enough evidence, for or against a particular intervention, it can be frustrating to clinicians. So how can we address this? This is an example of a living recommendations from the American College of Physicians that was based on a rapid living review. This is version 1. We've published the second version. And this is an instance where there was limited data. This was in May when we published this. And the researchers say that the data on SARS-CoV-2 are limited. So these practice points are based on the best available evidence on the effectiveness of N95 respirators, surgical masks, and cloth masks in reducing transmission of infection with SARS-CoV-1, Middle East respiratory syndrome, coronavirus, and influenza-like or other respiratory viruses in the community and health settings. So this guideline group was tasked with making a recommendation about protective equipment to protect against SARS-CoV-2, but very little of the evidence that was available even addressed this infection. So what are some of the ways that we can handle this making recommendations in the face of limited evidence. I think the first one is illustrated here, to be very upfront and clear about the fact that the evidence is limited. But even when you do that, the communication and the discussion of this article, people were not always recognizing that particular point. The other thing is when the recommendations are made, to use quality ratings, and when the evidence is indirect, to reflect that in the quality ratings, to very clearly outline the evidence gaps, which can be very useful to people who are generating more primary evidence. What should be the primary questions that those research studies are addressing? And I think most importantly is to help guide clinicians about the things that they should consider when they're making patient care decisions and public health decisions based on evidence that is indirect or of less than optimal quality. And the ACP guidelines group has done this by incorporating a clinical consideration section into all of their guidelines. And in cases like this, where the evidence is indirect and weak, the clinical considerations are more lengthy, but help the clinician really think through the problem, as clinicians always should, because even when a guideline is based on high quality evidence, there may be things that make them apply them differently depending on the particular patient's situation. The other thing that we've seen during the pandemic, so if you don't have clinical trials available, you're going to be including observational evidence. And particularly early in the pandemic, when there were large hospitals in Asia with many thousands of beds and probably equal numbers of researchers working at those institutions, we started to see different research groups reporting on patients from the same institution. And these researchers weren't necessarily aware of the other work that was being done. And so you would have, these are hypothetical, but one report based on 127 patients from Hospital X. While we were doing peer review of that article, we discovered that there was a report in another journal of 323 patients from Hospital X. And then a couple of weeks later, we got a report from a different set of researchers, same hospital, 628 patients from the same hospital. And it really was completely impossible to be able to disentangle the overlap between these groups. And when an evidence review team is reviewing these observational studies, I think they need to be very careful to try to detect this overlap and avoid considering these overlapping studies as independent pieces of evidence. But we've seen many examples where that care has not been taken. The other thing is that aside from typical observational evidence that lots of us as epidemiologists are used to seeing, like case control studies and cohort studies, there are increasing use of newer types of evidence during the pandemic, and the need to incorporate this evidence into clinical guideline recommendations. So this includes studies that are really more in the field of environmental engineering. This is a study we published several weeks ago that looked at fecal aerosol transmission of SARS-CoV-2 in a large apartment building in Yangzhou, China. And we really, we had to work hard to find peer reviewers who were environmental engineers and could help us vet this work. This has not been, to my knowledge, incorporated into a guideline recommendation, but if it were, it would be a whole nother set of quality measures that the evidence reviewers would need to be incorporating for this type of evidence. We've also seen many of the SARS SARS-CoV-2, the SARS-CoV-2 literature has many modeling studies in it, particularly to look at issues like the effectiveness of social distancing and other public health measures, the transmission period, the transmission of the virus. And as these modeling studies proliferate, there will be times when guideline developers, particularly in the public health area, need to figure out a way to incorporate modeling studies into guidelines, which is something that generally it was infrequently done when we were looking at more typical treatment-based guidelines. And this is an example of a study that we had to retract in Annals that was looking at the effectiveness of surgical and cotton masks in blocking SARS-CoV-2 infection. And this study relied a lot on lab virology. And we were in a situation where we missed something important about the minimal detection of the virus and the threshold for that was picked up after peer review when people with particular expertise in the lab measures used here brought them to our attention after publication. So I think there are studies related more to lab-based basic science modeling and environmental engineering that are entering this literature and need to be incorporated into guidelines. And while we have standard methods for rating the quality of randomized controlled trials and standard observational studies, it's the quality ratings and the methods used for this type of evidence are not either non-existent or not as well developed. So I'm going to end here and just reiterate the challenges brought to light by the COVID-19 pandemic. There's always a struggle versus speed versus quality. Both are important, but the balance can be delicate. And what we've learned at the journal is that sometimes it's more important to slow down a bit and not have to publish so many corrections or retractions. I think that we really need a standardized approach of how to handle preprints, rate the quality, update the literature when preprints are vetted and published in a traditional journal. I think we also need standardized approaches when evidence that forms the foundation of a guideline is corrected or retracted. We continue to struggle with the best way forward to make a recommendation. Should we be making recommendations when evidence is absent or thin? I think that, to help clinicians, guideline developers are going to feel compelled to do this, but it's going to be really important to outline the uncertainty, the evidence gaps, and importantly, help to guide the clinicians in the issues that they need to consider when they're making decisions about patient care and public health. I think we also need to think about more standardized approaches when we're looking at new types of evidence. How is it appropriate to pool such evidence? How do you rate the quality of it? And then with overlapping study populations, much care needs to be taken to avoid treating these overlapping populations as separate pieces of evidence. So I will end there, and I'm happy to take any questions or particularly answers to some of the questions I've posed.
Thank you very much, Christine, for very interesting talk, the opening talk. And I see we have the first question from Kara Alhaji Fulehan. I hope I pronounced it well and read it well. Would you, as editors of major journals, consider systematic reviews and meta-analysis that combine peer-reviewed and preprint observational studies with sensitivity analysis and quality rating for publication? Or are such reviews mixed at the level of editorial office?
I think that we certainly do, and we have considered, you know, such studies. I think that we do, you know, struggle with some of the quality assessment of that particular work. So we don't have any rules about not even considering such work. Sure.
Yeah, very good. Is there any other question? I don't see they coming from the chat yet. However, we will have space for the larger discussion after all sessions. And I see there is one more question from Ellie Ackel. So are peer-reviewed journals considering having their own preprint services?
There are some journals that do have their own preprint servers. It's not something that we're considering at Annals. I personally have some concerns with that because I think that there are some sort of conflict, you know, potential conflicts with that. But there are journals that are having their own preprint servers, and there are journals more common in the outside of the clinical, you know, the clinical literature, but in some of the basic sciences, there are journals that post submitted manuscripts that are undergoing peer review for public viewing. So it's a preprint server of sorts.
Very well, thank you. I don't see the next questions. And Ellie, thanks for the answer. So I think, well, there is one more. So Christine, one more question. Post-publication peer review is becoming more common. How these can be incorporated into systematic reviews?
I think that, you know, post-publication peer review is really important, and that is really the mechanism where, you know, that leads to many of the corrections and retractions that we're seeing particularly in this pandemic, but also in other times. When we correct an article, it's more often one of our readers detecting the error in that paper than the researchers or the editors. Ourselves. So I think post-publication peer review is really important. And the question, I think we need a way to incorporate, particularly when that peer review outlines important quality considerations that change the conclusions of that evidence. We don't have a systematic way of requiring the evidence reviews and the guideline based on that material to update it based on those on the corrected literature. It will, I suppose, happen in when guidelines are planned as living documents, but if it's not planned to be a living document, it's unclear how that would be, what the mechanism would be for having the guideline developers update the literature in real time.
Yeah, very good. I think we, to the handing the Holger answered regarding the Grade Pro. So I think we can close these quick question answers. For now, there will be the discussion to all speakers after our presentation within the panel discussion. So you can still submit your questions within the chat. And now getting a word back to Holger, we will introduce our next speaker.
Thanks very much, Miloslav. And thanks very much, Christine, for this first presentation. We will answer other questions as they're coming into the chat, hopefully throughout the session. There's one from Gerd. Just also in follow-up to Gerd, of course, we can do sensitivity analyses on the basis of study quality. I think that's one issue that was perhaps still outstanding, and we should discuss how this would be done if we include those type of preprint studies. It's a pleasure to introduce our second speaker, Dr. Stewart Spencer, who joined the Lancet in 1999, and throughout his time he has led the fast track team that aims to select, review, and publish prestigious manuscripts within 4 weeks of receipt. Although dealing with all areas of research, he deals primarily with cardiology submissions. Before joining the Lancet, Stuart was a full-time researcher leading various research teams in scoliosis, growth, neuroendocrinology, immunology, and fetal development. He has held posts both in academia and industry in the UK, Netherlands, Switzerland, and New Zealand. He also had 2 senior research fellowships at Leuven University in Belgium and a senior fellowship in bioethics for 5 years, visiting professorships at King's College London and Hong Kong University, and a doctorate of medicine from Umeå University in Sweden. It's a great pleasure to welcome Stuart, and Stuart will talk to us without slides. But Stuart, you will share your video, I'm sure, and yeah, we'll go from there.
Okay, well, thank you very much. To start with, the views expressed are mine and not necessarily the Lancet's. In fact, usually not the Lancet's. I have a reputation of being a bit of a contrarian, so the Lancet doesn't like to take my views, but that's something else. I'd like to think of it more as thoughtful than contrarian. I think it's my scientific training is to challenge all the time, of course, and that's what I do, and then come up with a different answer. Having said that, most of what I'm going to say is going to be supportive of what Christine's just said. So, but I'm going to take a slightly more philosophical stance on this. So the expectation is that science will fulfill all our material needs, and that's never been as apparent as it is at the moment. There's a belief, or I suppose I should say a hope, that scientists can magically produce a panacea for this pandemic. In an era where everything is instant, you know, the Google era, the public are impatient and expects results immediately, but that's not the way science works. With the outbreak of COVID, there's been an explosion of very rapid research on preprint servers. And the issue I want to address is how useful are these preprints in directing science and policy? Obviously, they're going to produce some evidence, but how useful, how reliable are they going to be? So I'm not suggesting that preprints don't have any use. I mean, the Lancet started accepting preprints in 2018. That was a question we just had from one of the members of the audience. We currently have over 6,000 manuscripts listed on SSRN. So we certainly see a role for preprints. We reject some for technical reasons, such as they might not have ethics approval. But essentially, everything gets published as a preprint, regardless of how reliable the findings are. The question then comes is, are they all really strong enough to advance understanding and direct health policy? Some of them undoubtedly are, but not all. And in my view, that's where the problem lies. And now you could say that collating all the evidence that's available smooths out the anomalies and the outliers. But actually what it brings back to is a mean point where nothing's changed. And there's a real danger with including unreliable data. I remember a quote from Franz Messerli, who was talking a couple of years ago at a Hypertension Society. And he said, "One rotten fish will spoil the whole bouillabaisse." I think that's something we need to bear in mind. What he's really saying is that including unreliable results leads to unreliable outcomes in systematic reviews. So I think that's something that we do need to be aware of when we're using preprints. So as I said, essentially all the preprints that are submitted to the Lancet are accepted. But in the print journal, we actually review fewer than 10% of the submissions, and we publish less than 3% of those that are submitted. And even then, we sometimes get it wrong, even with all the security of peer review and editorial revisions and so on. that leaves an awful lot of scope for weak or wrong information that might be included in preprints that haven't been peer reviewed to make wrong decisions on guiding treatment of billions of people. This isn't small fry, you know, a lot of people are going to be involved in this. Even so, with the outbreak of a completely new disease like COVID, the scientific community had basically no data on which to base their actions and recommendations. There was a call, obviously, for evidence to be made rapidly available, and this could be achieved through preprints. One can argue that that's not unreasonable. There are some problems, though. Early in the pandemic, we had looked at some modelling papers. These were needed to provide some indication of how the outbreak might progress. However, modelling without robust data underlying the assumptions is unreliable at best. It's probably better than nothing, but it's definitely unreliable. We saw that there were wildly different forecasts in the early stages of the pandemic about how it was going to roll out. That's perhaps not very helpful. Policymakers effectively had to guess at which of these models they thought were going to be realistic. I wouldn't think that guessing is a good basis for policy making. There was no good evidence, so basically it was guesswork. I don't think that's a sound way of going about things. So thinking about another question that was raised, would we accept preprints in a systematic review at the Lancets? At the moment, our decision is that we will rarely accept systematic reviews that use non-peer-reviewed data. This includes the grey literature, preprints, and conference abstracts, even though conference abstracts are at least superficially peer-reviewed. But most of us will know from our own experience, while I'm talking as a scientist doing a lot of research in the past, I would get the first results from a dozen patients and it followed exactly what I thought we were going to see, my hypothesis. Great, there's a meeting in Sydney. I'm going to put in my abstract and get it published there or presented there. And by the time I actually got around to the meeting, the next 20 patients had gone in completely the opposite direction. This is not unusual. Basically, conference abstracts are unreliable. And so the final results often give a different result. So we're also not keen on conference abstracts or peer review, pre-review stuff. So it's been said that journal editors are the guardians of the integrity of the scientific record. Sounds a bit pretentious, but you know, it is an important point. We do have a really important role in guarding science. And editors rely on peer review to give us the confidence that we can publish the papers. But peer review process is notoriously slow. In biomedicine, actually, it's quite swift compared with some other disciplines where articles can routinely take 2 to 3 years to be printed. Waiting 3 or 4 months for a biomedicine paper to be published is actually not so bad. But preprints can circumvent this delay even faster. But they don't give us the confidence that peer review does. So is there another way? Yes, there is. At the Lancet, we started the fast track process in 1999, as you just heard. And I've been running that fast track service since inception. As a researcher, I was impatient. I wanted to see my papers published quickly as well. Everyone does. So I thought this was a great way of getting papers out quickly, peer-reviewed, fully peer-reviewed, no cutting corners, fully peer-reviewed and published within 4 weeks. It's been very welcomed by researchers. And of course, it's very helpful in looking at getting fast results out there. And we can do it in sooner than 4 weeks in a pandemic situation. In very exceptional circumstances, we've been able to get full peer review and publication within 5 days. That's not so bad for getting results out quickly. It's as good as preprints, I would say. But we have the problem there that we have a peer review with our fast track, but we don't have it with preprints. And I believe this is a reliable way to get systematic review of data for reviews and meta-analysis. So my conclusion here is that preprints have a place, but I'm rather dubious of their value in informing public health. I have another more fundamental concern about the use of preprints. Science is under scrutiny like never before. The reliability of scholarly publications has never been more important if we are to maintain trust in science. If the public loses trust in science and respect for science, it could have enormous deleterious effects on all public health initiatives. We have to have some reliable conclusions that we can draw from these data. And as Christine alluded to, changing the recommendations very quickly, or even for that matter slowly, doesn't help with getting messages out to the public. Just looking at in the UK, the daily updates from Boris Johnson and his advisors on what we should be doing. We should wear masks, we shouldn't wear masks, we should go out, we shouldn't go out, we should go back to work, we should stay at home. Changes every day. People are losing confidence in science. For that reason, I think we should treat preprints with great caution and stick much more with going to peer-reviewed articles as the basis for systematic reviews and meta-analyses. Okay, well, that's all I have. I'm prepared to take questions, of course, if there are any.
Thank you so much, Stuart. It's great to hear your independent perspective, certainly influenced, I guess, by your experience in working at in fast tracking articles at the Lancet. If there are, I'm looking at the chat, if there are any questions in the chat. I do have one question. In short, are you suggesting that fast tracking is an alternative to preprints and to utilizing information evidence from preprints?
Yeah, I do think so. I think although I can see a place for preprints, as I say, and people are impatient to get their work out there, not necessarily for public good, maybe for their own good, but yeah, I think that we can roll out, journals can take this on, they can roll out fast track in the way that the Lancet has. Not everything is going to get fast track, but at least we can then sort of say, yes, we have a look at this, people have selected the important, influential data that's reliable. And then if all the journals started doing more fast track, making that available rapidly, I won't say we could do away with preprints, but we can use that fast track data for systematic reviews in place of preprint data.
Great, thank you. And there's a direct follow-up question from Gerd. Again, so you mentioned other journals are doing it. Christine mentioned that the Annals has an approach to that. Do you have a sense of what other major journals fast track as the Lancet does?
Well, there are quite a lot of journals are doing a small amount of fast track. The difference with the Lancet is that we took this on as a completely new approach, and we set up a separate team of fast track editors whose responsibility was to deal with fast track. That is our job. Other journals haven't been able to invest that sort of money, perhaps, and they tend to look at getting papers out rapidly so that they can be published at the same time as presentation at scientific meetings, but not necessarily doing them at other times. So I think it requires a dedicated team of editors to deal with fast track properly on a routine basis. And then those editors are available with experience to deal with pandemic type situations. So I don't know any other journal that's actually produced a fast track team specifically to do this sort of thing. It's ad hoc.
Thanks, Stuart. There's a couple of other questions that I will take some of them. Karla is asking, how many papers a month would you be able to handle in a fast track way? And what are, if you can allude to the key elements that helped you speed up the process?
Okay, how many can we handle? Of course, it depends how many people you have on your team. At push times, sort of for things like the European Society of Cardiology, which is a huge international cardiology meeting, I might be doing up to a dozen fast tracks in the month before. That's through that month, getting them through the various stages. And that would just be me. My rest of my team will be doing other fast tracks. So we can do perhaps a dozen at a time per editor. That is a lot of hard work. It does push things to the limit, not just at my end for getting peer review, but also at the production end. So that's really about the most I think that we could do. During the pandemic, we've had a huge number of submissions as fast tracks. One of the problems, of course, is that we have to then read them all and make a decision as to whether they are ones that we think are important enough to fast track. So we've been looking at 2,000 odd manuscripts over the past 6 months. And it's not just one person doing it. The way we do it anyway is that we look at them as a team. So my team has been looking at over 2,000 manuscripts and deciding whether they're fast track. That's before we start doing peer review. It's exhausting. Yeah.
Great, thank you, Stuart. I will take one quick other question because I think it's an interesting suggestion, and then we'll try to address the other questions later. But there's quite a few coming in from Kurt Berger. Could peer review of preprints by members of the guideline committee, for instance, as evidence is used, I editorialize this, as evidence is used in recommendations, be a solution? Could that support? Because one of the questions that we will address later deals with editorial fatigue and that overload that is probably there. Yeah, so is there editorial fatigue? Is that really the question? Well, the question is also around, could when evidence is used, studies are used, could guideline committees be part, is there a process to integrate guideline committees in this peer review? Because you would essentially get two birds with one stone. I see. As well as so better connection perhaps with, that's how I understand the question, better connection with guideline producers in that peer review process, assuming that it is not always easy to identify peer reviewers quickly. Yeah, I guess I hadn't thought about that because in general, we're not aiming to, routinely for fast tracks, we're not aiming to influence guideline committees and so on. In this pandemic situation, that would have probably been a good idea if we knew who they were and which guideline committees they were going to be. I suppose really we'd only be looking at things like WHO rather than local guidelines because it's been a global response that's required. Yeah, I think I will thank you for that suggestion. I will store that in mind for the next pandemic, if I'm still around, and see if we can incorporate members of guideline committees into peer reviewers. That would be a useful way forward, perhaps. Yeah. Thank you, Stuart. And Christine may want to weigh into that, keeping this interactive, and then we will, Christine, if you want to chime in, and then we'll go to our next speaker, Karla Soares Weiser. Christine, if you want to unmute yourself.
Okay, sorry, I was having trouble unmuting myself. So I think, you know, that's an interesting idea, but I think that when, you know, when we get systematic reviews that have included preprints or guidelines that have included preprints, those guideline developers and evidence reviewers have done peer review on the preprints because they've assessed them and decided to incorporate them into either their review or their guideline. So in a way that is being done by guideline groups that are considering the pre-published literature in their guideline formulation. So it may just be, you know, at some level it's changing the semantics of what's peer review versus what's system, you know, just part of the systematic review process. The peer reviewers, I mean, but if it's something is published as a preprint, except in a situation like the Lancet where they have their own preprint archive, you know, we are not doing, the journals are not doing peer review of that material. We only begin to do the peer review when people are interested in having their work considered at our journal. So it would really be the preprint servers that are incorporating the guideline developers into a review process. But I think more importantly, once a guideline development group is considering a preprint, they are for all purposes doing peer review of that content.
Thank you. Thanks, Christine. Okay. Thanks, Stuart, again. Thanks, Christine. We'll come back to general questions. There are quite a few questions coming through in the chat that I think will be great to address at the end of our session. I'll turn it over to Miloslav before Karla shares her screen.
Okay. Thank you, Holger. Thank you very much, Stuart, for very interesting thoughts and ideas which you shared with us. And for the next speaker, it's my great pleasure to introduce Dr. Karla Soares Weiser. She's editor-in-chief of the Cochrane Library. She's a trained psychiatrist, holds a master's degree in epidemiology and a PhD in evidence-based healthcare from the University of Sao Paulo. She has been working in evidence-based healthcare since 1997 and is an author of over 60 systematic reviews, including 33 Cochrane reviews. She has held numerous positions in Cochrane groups, including as a visiting fellow at the Ibero-American and UK Cochrane Centers, where she provided training in systematic review production. And Karla is also one of the leading persons in a Cochrane towards the COVID-19 pandemic, and she accommodated a fast track within the Cochrane Library for very important Cochrane rapid reviews. So Karla, you can upload your slides.
Okay. I'm having a message that I cannot upload. Okay, I think that's it. Yep.
Yeah. If you can share your video, it will be also good.
Get in there. Thank you, Miloslav. I'm just trying to find. Okay. How do I share my video? Sorry about that. I can't find the place to share my video.
Yeah.
Can you hear me?
We can hear you, yes.
Yeah, we can hear you and we see your slides. I will not in a presenting view. So maybe if you use more monitors, you need to choose the monitor where the presentation is.
Okay, I think I'm on.
Okay.
So thank you all very much. That's been very interesting to listen to our colleagues. And I think, thank you for the organizer. This is really very, very important for us to discuss and to find some ways forward during this time. So basically, I want to emphasize that Cochrane really supports the development of systematic reviews, set standards and methodological and guideline standards, and publish the reviews. Differently from the previous speakers, I'm going to focus more on the challenge that we had in developing these reviews, because I think it really showed the other side of what the discussion so far has been. That's been very helpful to all of us. And obviously, we are talking about preprints because we've seen with the pandemic a need for faster ways of sharing research evidence. And I think never been so clear the importance for us of having proper mechanisms on how we produce this evidence. And really, preprints of medical journals medical science has been really increased in numbers. Holger mentioned in the beginning that the numbers of research in COVID, it's higher than many other key areas produce scientific evidence. But it's not only preprints. Peer review articles have also increased for good reasons. We are all in a situation that we need evidence, we need information. So the challenge for us is how we actually incorporate. And the points I want to make here is whether there is really a lot of difference of what we are seeing in terms of the peer review and the preprints. The first way we look at this challenge is that at the beginning of the process, we created a study register to support authors develop the reviews. And this we created the study register because of what has been mentioned before. So basically, we wanted the point of contact for the authors of our reviews, and this obviously is open access and widely used outside Cochrane as well. But basically, for us, it was important that the authors of the reviews that we are trying to fast track, that they had one place that they could go and identify all the studies. At the beginning, we had not included preprint. Was not something we used to do in the past on our register. But became very clearly that it was a need to adapt to a new situation and incorporate other type of studies in systematic reviews. Therefore, the register had to really include preprints, but also, as you can see here, different types of studies of what we were in use prior to this pandemic. And we actually considered preprint of Cochrane reviews. Wiley has a repository, Wiley is our publisher, and we worked with them to discuss a pilot of adding all the Cochrane reviews done during the COVID pandemic as preprints. But we end up not doing that. And the main reason for that is that we have we put a lot of effort in our quality assurance process, both while conducting the reviews. We have clear standards, and but also, we have to publish the protocol before you start the review. You have to identify clearly how you're going to deal with certain situations, such as including preprints in the reviews. But we also identified that during this process of conducting rapid evidence synthesis, the quality assurance was really a process that we needed to pay even more attention. And for us, as Miloslav said before, the major challenge was really how to fast track this publication. So we've invested our resource in a fast track team. Cochrane reviews are usually large documents with a lot of areas, and it depends on peer reviewers with different backgrounds. So it was quite a challenge for us, but we have been able to publish all the COVID reviews within 3 to 4 weeks after submission. So I think that for us, the resource that we had was used to fast track the publication, and we felt that there was not really a lot for the publisher, for the public to gain with the preprint of Cochrane reviews before the quality assurance. But we also had other ways to share our evidence. So we signed the welcome statement, and all the systematic reviews published during the COVID are free for all. We also made available to the World Health Organization at the point of submission all the evidence that we had after the quality assurance process when the article is submitted. And the third thing that we actually are trying to, I started it now, is our Cochrane Research Integrity team is working on a project comparing. We know that not all preprints actually get to final publication, but comparing the preprint with the final publications in order to set proper guidance going forward, how we use preprints in our reviews. So for us, it's very important that we keep the standards in terms of quality assurance and work on provide the best available evidence that we can to our readers. It's fair to say that this has all been very challenging, like the previous speakers have said, and really very resource intense. I'm going to give you some examples of reviews that we've published with during the past 5 months, and the challenge that we had in producing these reviews. So we published 4 reviews during the past months on public health measures, one in universal screening, another one in quarantine, another one in digital contact tracing technologies, and another one in travel-related measures. Of course, that as described before, part of the challenge were the use of preprints, but I think for these public health measures, the main challenge were the inclusion of modeling in the studies. So this was new to us as well. We have never included modeling in our reviews. And we had to really identify proper guidance of how to assess this. Most of these reviews have used the ISPOR guidance because that was the only one that we, it was more accurate. But the key thing here was to have author teams conducting these reviews with expertise and understand the caveats of these studies, and also how we can use these studies and provide the evidence with the caveats. And I think that was really a very challenging thing. And I've actually, for this talk, spoke to all the senior authors on these reviews. And one of the things that they've said that, when you put together a team to do a rapid review, you really have to take into consideration the skills of the team so that you can have a reliable product, because everything is done much faster. And they said that one of the key things for them was actually to have people that understand modeling and understand how you can interpret these results or cannot interpret these results as was described before. So basically, a lot of these reviews have no meta-analysis. The synthesis is only narrative. And the other thing is that we put a press release of these 4 reviews together, just really to make the point that these are not really separate measures. And it depends. Applicability is something that the guideline developers will do and the countries will do. We're not talking about applicability. We're just trying to summarize the evidence for this type of public health measures. We have also embarked in a series of diagnostic test accuracy reviews that's led by Professor John Diggs from the University of Birmingham. And again, a lot of these reviews were initially published based on preprints. So the antibodies reviews, 54% of the articles were preprints. But one difference that Cochrane has a long-standing discussion, and we really update the review. So this became very important here. So part of all these reviews are being updated regularly, if they're called living reviews or not, but they have been, we've been agreed with the authors that they had to be updated regularly. And in the case of these Diagnose test accuracy reviews, again, a personal contact with John Dix, and he was explaining to me that what they did is that as part of their process, they not only did the critical praise of all the studies that they include, but they communicate with all the authors of these preprints to cross-check the results. And they're now updating these 3 reviews. And specifically for the antibodies review, most of these preprints there have now been published, but he's not seeing a lot of difference between what is published and what was published in the preprints, what is encouraging. However, it's very clear in the reviews that this update will then be an opportunity to cross-check and identify errors and correct some errors, because in a situation like that, even if you try your own best, you have to understand that there is going to be some errors, and try to minimize and get the information as accurate as possible to respond to the needs of our users. But I think what I wanted to also discuss is about living systematic reviews. Again, this is something that Cochrane has been involved and set the guidance and the standards for the past 5 years. But it's become extremely important here and quite a challenge for us. Because our guidance says, well, you do the surveillance, and once you see that the evidence will change with the studies, the new studies, you then do another update of the living systematic review. In this case here, and I'm just giving one example of these living systematic reviews, is the convalescent plasma. It was first published in the 14th of May, and most of the studies were preprints and were actually case reports. So there was really a big emphasis on the caveats and a big emphasis on that this review will be updated regularly. So the 10th of July, we published the second version of this living systematic review, now with 22 included studies and 1 RCT. And if I'm honest, we were sort of pressured because this topic became politicized, and the FDA then made a mistake here as well. So there is a third update on the way. I know that there are 4 RCTs included on the third update, but the key challenge here for us is that there are 98 ongoing studies, 50 of them are RCTs. We don't know yet if all of them will be published, if all of them will be finalized. We don't have all the answers of when, how frequently this review should be updated. These are things that we are discussing with our methodologists, and we are trying to identify ways. So one of the things that we do is using the Cochrane register to do surveillance, and then work with the authors and support the updates. But there is a lot of unanswered questions for us as well during this process. And my final slide is just to remind what both the speakers have said, and specifically in terms of evidence synthesis in time of COVID. It's really very important that we get this balance right between speed and the quality of the evidence that we are providing to policymakers. And I hope that we will continue to collaborate, because another important point during this crisis was the level of collaboration between different organizations, and how this actually supports finding proper standards on the way we should do it better. So thank you very much.
Thank you very much, Karla, for very important information of the Cochrane systematic reviews. And we are now having a question from Miranda Langdon. There are quite a few modeling studies in the 4 rapid reviews. Is Cochrane considering developing methodological guidance on how to include modeling studies in systematic reviews?
We've been considering that, but to be honest, it's a field that is new for us, very new to us. So we do not have, we have methods group for in most of the areas. We do not have on this area. And as I said, most of these reviews in public health have added modeling studies. And if this is the trend going forward, we might need to make some more considerations on that. So at the moment, it's really very much very senior author teams involved on these reviews, and making a point that there are people with expertise as part of the teams. But we will consider guidance if this continues to go forward.
Yeah, thank you very much, Karla. Because there is a short enough time, I will have a last question on this, and then I will give word back to Holger Schunemann. So Karla, one question from me. I know that within the Cochrane there is more than 100 important questions, and the Cochrane is prioritizing these questions towards a rapid review or living review production. And you showed the results of what was published in last half year. What is the capacity of Cochrane to accommodate next reviews within the next half year, let's say?
Yeah, I mean, I think this is a very good question, Miloslav, because basically we had to invest and we use our own resource, but our resources are limited. I think the key point in Cochrane is really Cochrane is a network of volunteers, and a lot of people came forward and wanted to work with us. So our resources were used in order to provide support, methodological support for the teams doing the reviews, in order to do the priority setting and make clear what are the questions that we will be answering, and also to support regular update of these reviews. So now we are working with other partners, including the World Health Organization, to see how we guarantee that the right reviews will be conducted. And in our case, given our mission, we are really also considering topics that are relevant for low and middle income countries. So more on this space, and we're making everything public in our website, and what are the areas that we were working and we will continue to work.
Yeah, very good. Thank you for the answer, Karla. And I'm giving a word back to Holger. I see there is one more question from Ili. We will use this question later in the general discussion. So thank you, Ili, for submitting this question. Word back to Holger.
Thank you so much, Karla. I do, there's a couple of things to follow up before we go to our next speaker, Gerd. So two things. One is, Karla, would you agree that most modeling studies, and this possibly also goes to Stuart and Christine, that we've seen in the COVID-19 pandemic and publication strategies, that most modeling studies actually come with very low certainty in the evidence as a result of most of the data that is actually utilized for modeling being from observational studies and the big uncertainty that exists?
Yes, definitely. And I think one of the main challenges is actually to assess the certainty of the evidence. I think it's one of the major contribution of these reviews, because in most cases, it's low certainty evidence. And as I said, we've chose to do a press release of the 4 reviews together, just to really make the point that none of this, we don't have enough evidence for none of these measures in isolation. And therefore, the measures, the public health measures, have to be considered together and according to the applicability in different settings.
Thank you so much, Karla. If Stuart and Christine have additional points on that, you can put them perhaps in the chat as we to move on about the certainty of the evidence. And I will introduce one other feature. We've discussed quite a bit about preprints, and I will launch our first poll. You should be able to participate in that about the use of preprints. Should we include preprints in evidence reviews for guideline recommendations? I will launch this poll now, so you can participate in that. And I will introduce our next and last speaker before we get to a general discussion and some additional polling questions. So Dr. Gerd Antes is a PhD mathematician and honorary professor at the University of Freiburg, Germany. He's emeritus since 2018. He set up the German Cochrane Center in 1997 and was a co-founder and board member of the German Network for Evidence-Based Medicine and a member of the Cochrane Collaboration Steering Group. His activities focus on quality of planning, conducting and reporting of research, and he's participated in a number of activities that influenced guideline development in Germany, and was a member of the Scientific Advisory Board at WHO for the International Clinical Trial Registry. Recent activities focus on methodological aspects of big data, personalized medicine, and digitalization, as well as new sources of bias, especially in the reporting from predatory journals, which will be part of his presentation. Gerd, pleasure to welcome you as a fellow countryman, and I will turn it over to you to unmute yourself and share your screen. So Gerd, you would first unmute yourself on the microphone button. Left bottom, it should be at the left bottom. I can also do that for you, okay. You should be unmuted now.
Can you hear me now?
I can hear you now, yes. And if you share your screen.
Okay.
And so while Gerd is pulling up his presentations coming there, the poll is open about the preprints. You should be all able to see the polling questions. If not, then we will address this. Gerd, over to you.
Okay, thank you very much. Let me start with a comment that this is really a fascinating session and I'm really glad to be here. And what I'm going to do now is I'm adding some views which may at first sight look not really closely connected to what we have heard before, but it actually is. And let me just briefly look at my conflicts of interest. So I'm retired, but I have a strong conflict of interest, non-monetary, on intellectual things, long-lasting commitment to evidence and systematic reviews. And I will take you through the view, what happens with journals which are now fairly known as predatory journals, have a close look at the history, show the characteristics, and if you work in this field, we have heard that several times before, you are immediately led to the tensions between pressure of time, volume, and quality. Classical publication is clearly from manuscript to publication. And what you see then, the big difference between classical access is subscription and licensing by libraries, and especially by the top journals, the control of volume. And this is completely different in open access, free access, and the pioneers are well known also how much that approximately means for one article. And what happens here, this is usually, there's a lot of ideology behind open access. What most people don't clearly see is somebody has to pay. And what is happening here is the pay system is moved and shifted from readers and users to writers. And the immediate consequence we will see that is that the control of volume is completely lost, and that means loss of quality in a restricted market. And simply, I call that very often, the poor can't read in the old times, and in the new times, the poor can't write. The name you inevitably come across in this field is Jeffrey Beal. He was a librarian in Denver in the US. And what you see here is he started Beal's list in 2008, and you see here the table how fast these so-called predatory publishers grew in numbers to 2016 to almost 1,000. And the history, in a bit broader sense, is this is happening under the background of open access. Preprint and dissertation platforms already existed in the 1990s. If you can look it up in Wikipedia, for example. They seem to be very modern terms, but they are not. They are classical tools, and they were very supportive and helpful in niches, especially in mathematics and other, in chemistry, for example. Beale published his list in 2008, and he had to withdraw it, close it 2017 for various obscure reasons. And since then, we are struggling to solve that problem of the extremely bad influence from here. So, for example, I'm not going into details in all these slides, but just to show where you can look that up. That's by Beale or from Beale directly, predatory journals ban predators from the scientific record. You can see it's always the same wording, the enormous damage to science by these practices. And universities and colleges should stop using the quantity of published articles. So everything, all these details are very well known, I assume, to all of you. What you see here is again the same wording, and this article is hardly known to anybody, extremely interesting to read. I think it's free on the internet if you want to understand what happens here, because what you see here is he was mobbed from his own employer, the University of Colorado, and this is a very bitter publication by him, why he stopped that list. And for example, also, really, I'm not sure whether that's true, but he here claims that there have been tens of thousands of researchers who have earned master's and PhD degrees and posts in the academic world by presenting publications from this field. That's also an interesting picture. It shows you where the people are sitting who do it and where the money goes. And if you would renew that, this is from 2013, if you would do that now, Turkey would also appear as a new player. And the effects are very clear. It's a massive damage of the scientific literature and of the whole scientific process and publication process. And one reason is that you can buy your publication in this new world, and that means you have enormous conflicts of interest. Top priority here is not produce quality, but mass production. We have seen these figures. And what we will see later is that these mechanisms have also been abused by, I call them respectable authors. Beale, he loved strong words, so he compares that with Inquisition. This may be a bit exaggerated, but that's the language he likes. And the big question around it or behind it is, how serious is this problem taken? And just to give you a quick impression, for example, this is the Committee on Publication Ethics, 2018. So it was on the table here. These are the international editors. It was on their table, and you see it's always the same wording. You also see that people are complaining. This is, for example, a statement from the peer review congress organizers, and you see that they were disappointed that they got not enough abstracts with respect to reproducibility, fake peer review, and predatory journals. So there was this mixture of people who were really taken seriously, especially on the organizational level, but also not very much interest to really go into it. And of course, coming back to Karla's talk, this is affecting evidence synthesis, and therefore it's really relevant for guidelines and the whole process we have been introduced into over the last hour. How difficult and how damaging is it? So this is a figure. The price of predatory publishing damage is $50 million that has been fixed by the FTC, the Federal Trade Commission, 1 year ago. And if you continue on that track, so this was a trial against the Indian company Omics International, who currently, as far as I know, are running about 900 of these journals. And how serious this is on a government level, so we see in Taiwan and also in India, that it really has penetrated into the system between politics and science. What on the other side happens in the established world? Well, most amazing is what happened in Germany. This is a group of, you see it here, 2 television stations, and the Süddeutsche Zeitung, that's kind of what I would call it, the German Guardian. And I worked with them for about half a year as advisor in the background. And they identified by name 5,000 German scientists from the normal established system, universities and research organizations who published in these journals. Most amazing. What's here at the bottom, these activities were closely linked to, you all know these invitations, a World Congress, for example, for urology, where they managed to get in and produced a film, which is most amazing, showing German scientists presenting talks there. And one journalist was successful in presenting a completely faked cancer presentation, which was absolutely documented that it was completely fake. So, and when this came out, this was in July 2018, the usual reaction and almost expected was that everybody, well, pointed to somebody else or said, you see it here, that focusing, for example, on fake science ignores the real problem of the publication process, or it's a storm in a teacup, it's not a problem. But nobody managed to say anything before 2018. I had it in my presentations in Cochrane context since 2015. Amazing, amazing. And also amazing was in parallel to that, during that time, we watched a growing or increasing war between they called it the Conference of Rectors in Germany and the big publishers. And the most serious confrontation was between them and Elsevier, which led to a complete breakdown on the system of literature provision to big universities. For example, one issue that was in the media, I think worldwide, that the University of Göttingen had no access to the Lancet. At the same time, so after ignoring, and this shows that it's really an open access issue, after ignoring the development for many, many years, suddenly there was a group of university rectors who really tried and wanted to change things. And with Springer, they were quite successful and proceeded to the point, and you see this here, that now 900 German institutions are part of that agreement with Springer, so that they have access since August this year, 500 to 500 fully OA journals, and members of those institutions can write articles and provide them, and it's paid by the so-called DEAL project. We picked up that development because that's the sad side of the whole development with my colleague Jens Türk. He's a dentist, so we chose journals in dentistry and just registered for a while how many invitations we got from predatory journals to submit our newest and excellent research to them. And we published that in an internal paper. We see this here, 2020. So if anybody wants to get such a paper, please just send me an email. And the negative result of that is the whole mechanism with these journals, and I showed you all the negative impact, is not declining. Our feeling, but we don't have really reliable numbers for that, our feeling is that it's still growing in spite of the need, or perhaps because of the need for more research results and speed. And for the discussion, I would just like to summarize my talk. The volume of these predatory journals and publishers seem to grow. Yeah, so I'm still monitoring how much I get, and it's very clear. It's not really reliable, but it's clear just from personal view. Preprint servers and predatory journals, if you compare their properties, They are very, very similar. And my current view is that there's a kind of a continuum between these two, at first sight, different things, which makes the situation even more difficult and also dangerous. They have no peer review. They are quick. Predatory journals, in principle, want some money for publication, but they very often have waivers. For example, if you hand in or submit your manuscript within a few days, then they very often have waiver of costs, and very clearly mass production and this, what was called earlier, tsunami of publications, is clearly on both sides. There's no protected room for scientific debate. That's one of the really bad impacts from both sources. Things are where they were debated in niches somewhere, for example, in mathematics, they are now immediately public, and if you're lucky, next day on the first page of New York Times. And my experience, and that's really urgent to debate that, from the last years, and especially from now, is there's no way to get rid of these bad influences. We have to go back to quality. Quality is to, in one sense, to beat banning. Yeah, that's the only way. There's no way to just forbid these negative activities. And that's one thing I'm really looking forward to discuss with you. Thank you very much.
Thank you, Gerd. That was also excellent and very thought-provoking. I really appreciate you taking the time and addressing this topic in the context of, again, the publishing of preprints, the quality of the evidence, what goes into systematic reviews. The floor is open to questions. Very thought-provoking, in particular the issue around, what is our platform for scientific debate before things become public. I think that's an important point. Transparency is important, but before things become public and are consumed by the public, in particular in the context of uncertainty. So we'll take questions in the chat. I will just share the results of our first poll, or I will ask perhaps Miloslav to do that. Can you see that now? The polling results?
Yes, I can see it. So hopefully everyone can see it. Gerd, can you confirm?
I think Stuart is smiling. He must be seeing it as well.
Okay. Yeah, very good. Regarding the first question, you see it's almost the same for yes, no, unsure. From it was I think about 78% of all who actually participated in this. So you see, we can confirm that it's not an easy decision, and there are many factors which would perhaps influence it. Yeah, regarding the guideline panels and the systematic reviewers. This is, I would say something what is the middle of today's reality regarding the preprints. So thank you for participating.
Thank you, Miloslav. It's funny, the wonders of technology. I seem to be the only one not seeing the results, despite the fact that I'm launching the poll. But luckily we have two moderators, and we had a few conversations before we would like to do how we would like to address this. Okay, one comment was just made while listening to Gerd. Somebody received 2 invitations from predatory journals to submit their publications, and I can relate to this in my email box. Any other questions from people for Gerd? We will launch a few more polling questions, and this addresses the guideline community, and why again while we are addressing general questions, I will launch this next poll. You can participate. The next polling question is about whether or not we should be offering recommendations on the basis of low or very low certainty evidence, and I particularly relate to guideline recommendations. So the poll is launched, and in the meantime, Gerd, there's two questions. I will start with Karla. Do you monitor if and how often predatory journals are getting indexed in literature databases like Medline or Embase? Do you have any information about that, Gerd?
Yes, we tried to follow it, and when Beale still existed, it was not impossible, but it was easier. But the problem was, his list was a kind of a negative list. And I think he was threatened legally so much, and also by his university, that he had to give it up. Then somebody else, I think he did that without being named, took over, and he tried to shift it to a positive list. But if you have a positive list, then you are, well, more or less Medline, but nobody has a precise view. Well, there are so many journals which are not a Medline, which are not predatory journals, that this is not very helpful. So currently we are without any really helpful tool to identify what is good and what is bad. And that's a nightmare because, for example, when I have to review a research proposal for a big research organization, then the authors may try to impress me with 35 citations. It is almost impossible with a quick look, at least at the names of the journals, to get an impression whether there are predatory articles hidden in that. So we are in a really difficult situation currently.
Thank you so much, Gerd. There is a second question from Zach Munn, and then we'll go to general questions and discussion with all of the speakers and everybody in the virtual room. Some predatory journals are now indexed in major databases, is Zach also responding. How can we deal with this in systematic reviews and guideline development? Any thoughts on that, Gerd?
Can you repeat the first sentence of the question?
Yeah. Yes, it was some in line with Karla's comment. Some predatory journals are now indexed in major medical databases. So how can we deal with this for systematic review development and guideline development?
Yeah, I think I can repeat my last answer. There's no clear solution how to deal with that. And I think Cochrane should set up a kind of a task force to deal with it, because the damage is so serious. I think it's worth the effort to have some specialists to deal with it. But you have to do it more or less manually. You have to look at these journals and then try to put them into one or the other corner, good or bad. I don't have better advice for that.
Thanks, Gerd. Thanks so much. So definitely a tricky issue, very tricky issue, in that considering publications in these type of journals for systematic reviews and guidelines, and that really makes our life right now quite challenging.
Holger, can I add one sentence?
Sure, add one sentence, and then I will be closing the poll.
Yeah, if you look at these web pages, so some of these journals, I think they have a staff of 1 or 2 persons, but they look absolutely perfect. And for example, there are examples, and of these 5,000, there are quacks who kind of developed a cancer drug, for example, and more or less, well, they sell them in that level, but even for me, it's not simple to recognize that with one glance.
Thank you, Gerd. Okay, I'll be sharing the results of our little poll on should we offer recommendations on the basis of low or very low certainty evidence. And as it turns out, I'm again the only one not seeing it. Luckily, somebody is sharing these slides with me, or the results with me. There is, I think, a majority indicating yes, with some stipulations. In particular, during public health emergencies, there's about 25 or 23% of people saying, no, really, we shouldn't be offering recommendations on this basis. And this reminds me of the only clinical trial, randomized controlled trial that I'm aware of, looking at this issue, where we randomized users of recommendations to scenarios and asked them whether or not they would like to see recommendations on the basis, real life scenarios on the basis of these low certainty recommendations, and the overwhelming majority said actually yes, because guideline users come to guidelines to get an answer. But we need to be able to communicate the uncertainty around that very well. So I will, there's one direct follow-up question that I will start with before Miloslav perhaps asks these questions, ask additional questions. And that really relates to considering everything that we heard today, what about rapid evidence synthesis? So rapid systematic reviews, whether based on preprints or not, including predatory journals. And in this context, do living reviews, a later topic during this series, in fact, session 4, do living reviews improve the quality of evidence synthesis? In other words, the process of maintaining a review over a period of time, and the journals have experience with that, does that improve the quality of the actual evidence synthesis? It will improve the quality of the evidence, no doubt, but what does it do methodologically? Does it reduce bias in the actual review process? I will post this question to our speakers, and also looking for any answers in the chat before we go to our next polling question.
Can I start, Holger?
Please start, yes.
I think this is very, very important. And I'm going to say, when we started putting together teams for rapid reviews in the beginning of the pandemic, we actually made some mistakes of just letting the authors do the rapid review and then submit it. And as I said, part of what Cochrane has, the strength is actually the fact that we have a big methodological pool of people and that can work with us to support the development. So we went back. We've decided that even for rapid reviews, they had to have some guidance and criteria. Number one, they had to have a protocol pre-published, well, not published, but at least assessed for quality and comment. But number two, that the author team had enough skills to deliver the review fast. So, and we set also what were the criteria of areas that we would accept the process to be fast-tracked, and what were the areas that we would not accept, such as quality appraisal of studies and risk of bias. So I think it's really something that we are learning, and rapid review, in my view, has a place. It's important, and for some of them, the way forward is actually maintain this review as living systematic review, so that we can provide the update and work on the caveats. There's really, it's a place for it, but we need to be clear that the big part of it is really assessment of uncertainty of the evidence.
Thank you, Karla. I wonder, Christine, Stuart, Gerd, any additional thoughts on that?
I'll chime in, Holger. I think, I don't know that we have enough experience with the living reviews yet to really know. My observation has been, I do think that they will get better over time. And we've actually seen, as the evidence emerges with some of the updates, adjustment in the criteria for inclusion, either making it more broad or more narrow as we learn more about the particular topic. So I think that there is an adjustment for the evidence hopefully will improve in quality, and the quality and the applicability of the reviews have changed. We've even had a few cases where the living review was sort of completely, it sort of was killed, and the guideline group and the systematic reviewers came up with new key questions, because the questions that they developed early in the pandemic, as we learned more about modes of transmission, were not really on point anymore. So I think, you know, modifying the questions, that's really a fundamental issue of quality of the review. And so I do think that that process will improve the quality of review over time. But as Karla said, you still, you can't make too many shortcuts, or there are going to be mistakes made. And in the end, you know, that is not worth getting something that's incorrect out quickly is worse than getting something correct out more slowly, I think, particularly in the pandemic.
Thank you, Christine. Stuart?
Yeah, okay, a few observations. I think that initially my thought for living reviews was that these were obviously a good idea. Yeah, right. But then I started thinking about it in a bit more depth, and I was not quite sure about it, because what does it do? You may get some results that overturn your initial conclusion, in which case we're left in a position of uncertainty again. A lot of people will be following the old guidelines based on the systematic review, perhaps, without going back to check. That's our guidelines, that's what we're going to do, no further thinking about it. Or it just supports the original conclusion and perhaps produces a little less variation. The credibility interval is better, but actually, who cares about the credibility interval being better? I mean, obviously, we, as scientists, we do, but as practicing physicians, actually, they don't care about that. So what is the value? You either get certainty by overturning the recommendations, or nobody cares about the increased reliability of the result. So I'm not sure that they are useful.
Thank you. Thanks, Stuart. And having heard from the three of you, Gerd, do you have any addition to that? I will launch our poll in the meantime on that particular question.
Yeah, I would like to give a political answer. I think we simply can't afford not to go living, because science is so much under pressure as never before, at least as long I've watched it. And the big problem, yesterday, for example, we had a big meeting on the national level, how to survive the forthcoming problems in autumn and winter. And that was more or less science-free. And also with respect to uncertainty, if newer trial results or study results are not included, somebody else will do. And so what we watch currently, that every single study is interpreted and going into the media and more or less increasing the confusion and irritation. I think there's no simple answer, but I think not doing it is a very dangerous path for science.
Thank you, Gerd. That's really great. And in the meantime, we will have the results of the polling questions. Do rapid evidence synthesis, in particular, do living reviews improve the quality of the evidence? And we'll end this poll. We have about 1 minute left, and before I finish with a couple of slides, I would really like to thank everybody, in particular the speakers, for investing this time. I think this session has been extremely informative. I'm glad we were able to record it and will make it accessible to others. Simply because also I think many of my North American colleagues didn't realize that 10 a.m. was 10 a.m. UK time when they registered, so they will have access to this recording. We did this session specifically at this time to also allow participants from the eastern regions of the world to participate in reasonable time zones. Our next session will be at 4 p.m. UK time, session number 2 on rapid guidelines. I would also like to thank the staff that is working behind the scenes to help us make these sessions possible at McMaster University and at GIN. Again, thanks to all the participants. I'm looking at sharing the results of this last poll, just to give you the answer also before we finally stop and before I turn over to Miloslav. There is a few other announcements. So first of all, our GIN website that is regularly updated and provides some informative links on GIN on COVID-19 resources, which was the big topic here. Our launch of the International Guideline Credentialing and Certification Program in partnership with GIN. And then finally, another thank you to everybody who has been participating. If you have questions about the Guidelines International Network, we appreciate your feedback, and also to inviting you to take part in our post-webinar evaluation. I go to the last results, and most people are unsure, possibly because they didn't fully understand the question. I got one comment at least that it was not clear. Most other people think, yes, there probably is improvement to the process of the quality of the evidence synthesis itself with making reviews a living. Miloslav, final words for over to you before we close. And
okay. Excellent. Thank you, Holger, and thank you all speakers for excellent session today, and also our participants who raised interesting questions. And my final words will be to invite you to our another sessions which we prepared for you. The session 2 on rapid guideline development will actually start today, 4 p.m. UK time. So hopefully we'll be able to accommodate our US colleagues as well within this session. Then session 3, recommendation mapping, which will be tomorrow, and session 4 on Friday, living recommendations. So looking forward to see most of you again, and thank you very much.
Thanks so much. Again, thanks to the speakers. Thank you, everybody. Bye-bye, and see you a little bit later.
Bye.
Bye-bye.
Bye-bye.
See you.